It's just a huge honor for me today to be podcast interviewing Dr. Porter Jones, MD, MBA. He's the founder of Dr. Porto, a chain of medical and dental clinics in Sao Paulo, Brazil, focused on providing high-value patient care to the medically underserved. Prior, Dr. Jones spent 4 years at Hospital Albert Einstein, where he managed the oncology department as well as the medical practice division. He currently is the CEO of Boka Sciences, an oral health company focused on preventative care through the diagnosis, monitoring, and treatment of xerostomia, which is why I brought him on the show. We just need to know more about that. Dr. Jones is a graduate of the University of Utah of Medicine, 2009, and has an MBA from Harvard Business School and actually knows the godmother of healthcare, Regina Hertzlinger, who we had on the show back in the day. Amazing to have you on the show today. How are you doing?
I'm well. Thank you for having me. It's a pleasure to be here.
So when's the last time you've been to Brazil?
About a month and a half ago. I still make it down 4 to 6 times a year. I love being there. I love the culture, the people, and business down there.
So all of your medical dental clinics in Brazil are in 3 cities? It's is that right? 3 cities mostly? 4 cities.
3 cities on the four separate locations on the outskirts of Sao Paulo, in the medically underserved areas of Sao Paulo, where patients don't have adequate access to good medical and dental care. We wanted to give them opportunity to receive the same type of medical and dental care that everybody else is receiving in the center and the more robust areas of the city. And we took the clinics and the care, physicians and dentists to them, rather than them having to come into the city to receive proper treatment.
And where does this come from? I mean, how do you just all of a sudden have, I mean, most every dentist listening to you right now only has 1 dental office. They can barely manage that. Yeah. How does your journey go where all of a sudden you own 4 dental offices in another country on the outskirts of what is the largest city in the Americas, isn't it? Is Sao Paulo bigger than Brazil? I'm bigger than Mexico City?
It rivals Mexico City. I think one or the other is going to be the biggest, but yes, It's one of the largest.
And they're both bigger than the largest city in the United States, New York City. I mean, in fact, the largest lecture I ever gave in my life was in Sao Paulo to 4,000 dentists in the year 2000 at the Aesthetica Health. And I said to the guy, I said, did you just say 4,000? And he goes, yeah. And I mean, it's just, how many people do you think live in that metro?
About 20 million people.
Wow. Yeah. Wow, that is so tell us about your journey. How does little boy Dr. Porter Jones end up in Brazil with 4 dental clinics? And you're an MD, not even at DDS. How does this happen?
It's a good question. When I was younger, I lived in the southern portion of Brazil for a couple of years in the state of Paraná. And I lived in the cities of Curitiba and Iguaçu Falls. I think most people are more familiar with Iguaçu Falls, the large waterfalls in the southern portion of Brazil. After medical school and graduating from business school in 2011, that is when Brazil may have been just the hottest country on the planet. And I thought it would be an interesting opportunity, both career-wise and for my family, to go down and rekindle what I'd learned and loved about Brazil and look for and start a career down there. So I landed with Albert Einstein Hospital. Albert Einstein Hospital is one of the largest and is considered the best private hospital in all of Brazil and frankly in all of Latin America. When I arrived there, I oversaw the oncology department along with the medical practice division, which focused on the IT and the outcomes of what was going on in the hospital. Now, to give you an idea, Albert Einstein Hospital looks like a 5-star hotel. There's not much to compare it to here in the United States, just a different level of care. Along with that care, though, is very restricted access of those who can actually go to Albert Einstein, afford it, whether it be through their insurance or out-of-pocket pay. Great place to innovate, great place to treat. But at the same time, there was something that got me about the restriction of access. As you would know, Brazil just has the divide between the haves and have-nots is huge, and most are on the have-not side. and they don't have access to adequate care. There is a public system in Brazil, but at the same time, that is a lot like what we hear. It's not always up to par on standard of care. And in addition to that, it can take months and months to get that type of care. So as my time at Einstein was coming to an end, or as I was mentally preparing to do something else, this idea of working in the impoverished and medically underserved areas of Sao Paulo was very interesting, and providing them with medical care and dental care as well. So we got together a small group of individuals for investment, and we decided that our plan would be to take medical and dental clinics to the medically underserved, to the outskirts of Sao Paulo, and provide care to them where they are living at a price that they can afford. So our business model was take the best graduates from the most prestigious schools in Sao Paulo, the young graduates, pay them slightly above market, and really push high volume so that we could decrease the price for these individuals. So for an example, we would charge anywhere between $8 and $10 US dollars to fill a cavity, or $14 a month for maintenance on braces for individuals that wanted braces. This allowed us to, again, like I said, provide care to individuals that just were not getting it. The dental side came about because the dental portion of the public healthcare sector in Brazil is much worse than the medical. And we started to find very quickly that there was a high demand for dental care, bringing new technologies or technologies that they just didn't have access to prior. So we utilized and brought down some technologies, some basic things from the States, implemented a full EMR system, which was not overly common down there, so that all the patients could be seen in any of the clinics if they happen to be in different areas of the city. And we had a great time. Within the first year, had about 5,000 patients going through the dental and medical clinics. And we felt like we were, both profitable and doing good for the community. Ended up being a great project. And I learned a lot about dentistry. That's where I cut my teeth in dentistry, learned about the operations, learned about techniques, what's important. And I also then really began to understand the importance of prevention. If we can prevent more, we're leaving the money in the patient's pocket and not having them have to spend their time, money, and go through procedures if we can do that properly. And that became an interesting aspect, or something that I noticed very quickly, that we seem to do decent in medicine and that we're just not quite up to par in dentistry in regards to prevention. So it became an interesting focus, and that has continued on since returning back to the States, trying to look at this preventative dentistry side of the market.
Now, when you say your 4 years at Albert Einstein, was that in Philadelphia?
No, that was Sao Paulo. So it's a Jewish-founded hospital, much like some of the other Albert Einstein hospitals. They're all Jewish-founded. So the Albert Einstein Hospital is fully owned independently down in Sao Paulo by local individuals.
Wow.
So I ended up spending 7 years in Brazil during my time after graduating business school.
And so when you went, what made you go down there the first time? Was that a mission, a church mission for yourself?
Yes, that was a Mormon mission when I was 19, and was sent down to the southern portion of Brazil to spend 2 years there, learning the language, culture, and obviously spreading what I was down there to do.
Yeah, I mean, did you feel like you won the lottery getting to go to Brazil? I mean, I've had patients who almost cried when they found out, they were going to go to, Kansas or Oklahoma, and their buddy gets to see another continent or a country. Did you feel like you won the lottery?
Oh, I was super excited. And you've been. Brazil is just a wonderful country. So much going on there, so much to learn, wonderful people, great culture. So I was extremely excited, and it didn't disappoint. The 2 years were fantastic, and I was more than happy and excited to go back.
So you're an MD, you're a
Hmm.
dentist, you've worked in the top echelons of, the most care that's the Mercedes Benz care that the poor. Has it questioned your beliefs and foundations and what system to deliver healthcare? I know it's a huge debate. If the government gets too involved, it's socialism. If free enterprise gets too involved, it's market price segmentation, which a lot of people
Yeah.
don't sit easy with. How was your evolution? How long ago did you graduate from med school? What year was that?
2009.
So a decade, and
Yep.
you're a really smart guy. So how has your views changed in the decade of graduation to today?
That's a great question. At the beginning, I felt like we had a wonderful system. I still do think there are many aspects of the US system that are great. My perspective was completely changed down in Brazil. Down in Brazil, the onus is put much more on the patient. The patient needs to go shop around for what type of care and treatment they want. The patient needs to understand what type of physicians and dentists they are seeing. A lot of the payment is out of pocket. For those that have insurance, even them, they need to pay out of pocket and then they get reimbursed directly from the insurance company. And it's an interesting dichotomy when you are putting up the money, when you're fronting a good chunk of the money, you sure want to make sure that you're going to be reimbursed. You do the legwork to make sure that everything is pre-approved, that it's accepted. Now, in my dental and medical clinics in the outskirts of Sao Paulo, these individuals don't have access to private health insurance. They either go to the public system or they pay out of pocket. And again, it's interesting how market dynamics work when you're paying out of pocket. It really becomes a battle of who can give the best care and who can do it um, in the most inexpensive manner. And the patients are very involved in pricing, what they're going to get done, how they're going to get done, or how they're going to get it done and when they're going to get it done. And I've really moved to the side of we need to put more onus on the patients on both the medical and dental side to be part of the decision making, part of the shopping process, and deciding what is going to be done. I think here in the States, as we know, it's just easy when insurance is covering everything to say do any sort of procedure, any sort of radiological exam, and it'll just be covered. And down there, that's just not quite the case. You want to be more diligent on what's getting done and if it really needs to be done or not.
Well, when you hear people talk about healthcare, it's just not a clear. They don't think logically like they do with their smartphone. I mean, there's no federal government agency that monitors a smartphone, but we have a Department of Agriculture for wheat farmers, and all the wheat farmers I knew back in Kansas didn't have anything kind to say about the government regulation. But it just
Sure.
becomes a very emotional. Like they talk about fraud for Medicare. And it's like,
Mm-hmm.
no one ever looks at the bill because they have no copayment. I mean, if you just made a standard 5% copayment, your fraud would be gone and everybody would start shopping for price. But when you say
Yeah.
that, the people who they just think you're crazy because they point to this poor person who they don't want to have any involvement in this decision. And so are you going to kill economics? I mean, is economics a joke to you because you feel sorry for this poor individual? So it's just so emotionally complicated.
Yeah.
What advice would you give for the American system after a decade of this?
I would say, again, put more onus on the patient, make them be much more involved financially in what is being decided and the care that is being given. I know this was started and tried through copay, but when you're talking about a $30 copay for a $2,000 procedure, I don't think most people care about that $30. Going back to the Brazil system, you may pay out $1,800 up front out of your own money for that $2,000 procedure in hopes that you then will be reimbursed directly from your insurance company. You're going to be much more diligent in making sure that that insurance company is going to reimburse you and that you really need that procedure because you are putting the money up front and having that capital outlay at the beginning. And it's just interesting when you see bills and when you're passing credit cards before you're getting anything done, you think twice and you want to make sure that you are getting exactly what you believe should be done in conjunction with the recommendations from your healthcare professionals.
Yeah, and I know doctors right here in the valley of our own hospitals who say, yeah, my patient had an emergency, went there. The first thing he did is took some $3,000 MRI, CAT scan, whatever, and it had nothing to do with anything. And but if that hospital would have said, well, you give us $3,000 right now, and then it'll pay you back, they would start thinking, well, why do I need this? And it's just when I always hear Canadians saying, well, my dad had this major operation and his only bill was for a Netflix movie. It's like, are you bragging that your father had zero feedback about the price, the cost, the system? Really? I mean, who is telling you that this is a good idea? I mean, it violates every, it's like economics is a joke. Everything is a joke. When you take away these most basic things. But I do have to say that in America, like I've learned from doing the water fluoridation thing from Phoenix twice, because it expired after 20 years, had to go do it again, that a quarter of Americans will never be in a frame of mind to analyze the water fluoridation issue. So you just have to give up. And right now, I don't think there is a... I think between the ones who see more government involvement, socialist versus more free enterprise movement, I think it's going to be a stalemate for my whole lifetime. Do you see anything breaking in this debate? I mean, it's been going on for over a century. If you read the book, the Pulitzer Prize winning book, The Rise of Healthcare by Paul Starr, which I think is the greatest summary of U.S. healthcare system ever. I mean, hell, it came out in 1984. It's one of the few books where I read it and then like 6 months later just had to read it again. I mean, this debate's been going on for a century.
Yeah. I don't see in the near future anything changing. There's too much money, too many corporations involved that don't want it to change in a lot of aspects. I mean, going back to the same idea, prescription medications, there's nothing covered in Brazil. You get prescribed a medication, you go to the pharmacy, you pay 100% out of pocket. I can't imagine the pharmaceutical industry here in the United States ever giving up what they currently have in regards to reimbursement and how things are paid out. And as you can imagine, the prescription medications are 10% of the cost down there that they are up here because you are all paying out of pocket. There's just too many factors at play, too much money changing hands in healthcare in the United States for what I see something changing in the immediate future.
Yeah, so you got the long-term economic issue where big business always colludes with the lawyers and the government to pass all types of anti-competition, all types of regulatory environments, which is only created to drive up their profit and earnings. But as I noticed in the water fluoridation and medicine, but then you have a whole nother group where they dislike the government so much. Like I had people say, yeah, doc, I believe you. And you read all this stuff. That's all cool. But I don't want the government doing anything for me. You know what I mean? In my water fluoridation. So there's such a strong, you're up in Utah. There's a huge anti-government contingency up there. When you say so, a lot of conservative people, I mean, Utah, Kansas, Texas. I mean, there's just a lot of people who do not want to get in bed with the government, even if it's for a good reason. You know what I mean?
Exactly.
So talk about your journey. The reason I brought you on was none of that. It's xerostomia. It just keeps getting to be a bigger problem, which I believe is driven mostly from polyphagia. I mean, you start having all these. I mean, I'm in Phoenix and a lot of retirees, and my God, they're on 5, 6, 7 different prescription medications. And so right. Talk about your journey. How did you? After all your journey, end up in xerostomia?
Yeah, you bet. So the company was founded by a brilliant man named Grant Donovan. He has an engineering degree from Vermont and an MBA from Stanford. And he came up with this as he was investigating further and further the ability to measure dehydration. Well, as you can imagine, dehydration is very difficult to measure, as we've got so many factors that do affect dehydration or the ability to measure that in the system. And as he was moving along this path, he realized an interesting market would be measuring salivary flow and being able to diagnose xerostomia. Grant took this company from California, as he's a Utah resident.
And it was Grant. You said Grant Donovan was the pioneer of this.
He's the pioneer and the founder and the inventor of the system. When I moved to Utah, Grant was working on this alone, pushing it forward, FDA approval, et cetera, and I met him. We hit it off, and with the background that I have, operating dental clinics, understanding dentistry, along with having a medical degree, it just seemed like a great fit putting Grant and I together to push this company along. So for the past year and a half, we spent time perfecting the device, getting it through FDA regulations, going through pilots and testing in numerous dental clinics, talking with industry, talking with key opinion leaders, and working to really hone what we want to provide to the dental clinics and provide to the patient. And here we are. We're still at the very beginning of the journey, but we're having really good feedback, and we're working on this entire preventative care platform. We really believe that this device can be the center or the base of preventative dentistry. And we hope that other people will pile on and be part of this movement and continue to work in this area of prevention, and do as much as we can preventing issues rather than just treating them.
So your first say business model is more in the diagnostics of xerostomia, yes, not a pharmacological treatment.
We do not have the treatment, but we have been working with great companies that do provide the treatment. So groups like Forward Science that has the supersaturated calcium phosphate rinse. When chatting and discussing with groups like Elevate Oral Care, and these other groups that do have treatment options. Working together with them, we can test and screen all patients, and once that is done, we can give recommendations, or at least allow the dentist to understand what's out there on the market for treatment or for prevention in regards to this. And if we can have these unique partnerships alongside of us, it allows us to create that complete package, or at least allow the healthcare professional to understand what needs to be done after the diagnosis is made, and what are the care protocols to go through when working with a patient that has xerostomia or hyposalivation.
Okay, so podcasting is a young kid's behavior. So I always tell the kids, shoot me an email, howard@dentaltown.com. I love the comments on the YouTube channel, but a quarter of them are still in school, and the rest are all under 30. So I'm going to start with just basic. First of all, why does a kid in dental school, and he's probably sitting there trying to learn how to do a filling or a crown or a root canal, why does he need to know about xerostomia? And what are you how are you measuring it? And how does your measurement measure xerostomia? And why is that a problem? Just start with the basics.
Sure. No, it's a great question. Saliva has so many protective factors in the mouth. It is your natural barrier against periodontal disease, against cavities, against gingivitis. We've been told by numerous deans of dental schools that with good saliva, you really should never have cavities. So we want to be able to provide or look at this in a pragmatic way of, let's make sure that we're doing as much as we can on the protective factors, which is saliva, to basically give care on a year-round basis, or promoting good salivary flow. And that starts with going ahead and monitoring it. And I think your question is great. Yeah, you're learning how to do root canals. You're learning how to do the procedures. In the end, as a healthcare professional, you don't only want to react, you want to be proactive. And we saw this in medicine 15 to 20 years ago. People didn't quite understand or believe in the preventative aspect and want to invest in it. And now it's starting to prove that this is a very hot market, and very interesting to patients. And patients are getting more involved and more attuned to prevention rather than simply treatment of the problem. And we want to be part of that, allow a platform where young dentists and all dentists alike are promoting preventative measures so that they're helping promote good oral health rather than just treating the sequelae that could come from low saliva, poor oral hygiene, etc.
So what is your device? How does your machine describe your quantum mechanics machine? How is it made and what is it measuring?
You bet. So it's measuring, just as the literature shows, it measures how much saliva a patient is making in milliliters per minute. So the test can be done at chairside in the office. It has two disposable sponges that are placed in the patient's mouth, and it takes about 65 seconds to run the entire test. Now, there's an LCD screen, a 5-inch LCD screen that walks the healthcare professional through every step of testing the patient. So right at the beginning, the first disposable swab is placed in the patient's mouth to zero out the mouth. Then the patient rests or allows the saliva to pool under the tongue for 60 seconds. As this saliva pools, at the end of 60 seconds, you take the other applicator, place it in the patient's mouth for 3 seconds, place the applicator then back on the reader or the device, and at that point in time, you immediately get a digital readout, which is in milliliters per minute. We provide the healthcare professional with the ranges of what these readings mean. So anything above 0.3 milliliters per minute is considered normal, and anything below 0.1 milliliters per minute on this read is considered xerostomia.
Okay, so say those two numbers again. A saliva.
0.3 or above, 0.3 milliliters per minute or above is considered normal salivary flow. So at least on the quantity of saliva, you have the protective factors that you need to prevent oral health issues. As we do know, there's also quality, so we can look at pH and some other issues, but this is at least the quantity or the amount of saliva the patient is making. 0.1 milliliters per minute or below is considered very dry or xerostomia. These patients need immediate treatment, and we can talk about treatments if at your discretion, but these are the patients that need immediate treatment. There is then that middle range between 0.1 and 0.3. You're not normal. You're also not xerostomia, but you are low, and you will also require some sort of treatment, a less robust treatment than if you're xerostomia, but you will require some treatment in that range. Now, some interesting numbers through our populational studies, we're finding around 20% of the population has xerostomia, or they're below that 0.1 range. And then we're finding an additional 40 to 45% is in that gray area, or that area that is below normal and slightly above xerostomia, but still does require some sort of treatment. So when you're looking at the adult population, 65% of the entire population is somewhat low on the salivary flow that they're producing on a day-to-day basis.
And is age very dependent on that? I mean, is this an elderly thing mostly? I mean, they always talk about the over 500 medications that cause xerostomia, and of course, seeing health histories on patients all day long. The kids are on almost nothing, and the old timers are on lots of pills.
Yeah, and that's a great question. And we do see the older individuals get, the higher the incidence of hyposalivation they tend to have. And we believe and we know through looking at these patients that most of that is correlated with the amount of medications they're using. So you're exactly right. Over 500 medications that cause a decrease in salivary flow. And naturally, as we get older, we tend to be on more medications. We tend to be on more blood pressure medications, anxiety medications, medications to treat depression. And the more we have this polypharmacy as the population ages, the more we're going to start to see, or we are seeing, a lack of healthy saliva.
And so here's another way to look at the healthcare deal. I mean, when you're a dentist, you really understand polyphagia. So you're looking at these prescription pills and you're noticing how they're affecting oral health very upfront, personal, and close. But when you look at the data on how many people are killed in the U.S. hospital system, I mean, the low ranges are 180,000 a year, all the way up to 400,000 a year. I mean, it's like cancer, heart disease, and hospitals. So going back, okay, why would you want to make this machine that kills 300,000 people a year free? I mean, so I'm very, very frightened of a system that encourages that they always have a cure or a treatment, and people want to believe. So they want to go to the hospital, they have a problem, they give them pills. It's like, but are you being transparent of how many people this is killing? And so now, I mean, so it's a very complex, nuanced issue, because I look at all these people, and when you say to them, are you sure you should be on all these medications? And they look at you like, my doctor gave them to me. And it's like, they want to believe, and it's just, it's frightening. But I picked up very early, back I got out of school in 87, and I figured out by 90 that all the men in my practice that were 90 to 100 and parking their car and walking in, they weren't on any prescriptions. I mean, it was like, why should I even take your blood pressure or temperature on? I just want to know if you're taking any pharmaceuticals. And if you're not, you're probably really healthy. So polyphagia is just and it's going to get worse and worse and worse, isn't it?
Oh, it is. We look, just like you said, we look at all treatment just based on pharmaceuticals. You can live the life the way you want to live, and there will be some sort of drug that will fix it. And it's been shown and proven that food causes a lot of these issues and can also cure a lot of these issues depending on diet. And we've unfortunately gotten to the point where we eat what we want to eat. We are as sedentary as we want to be, and we just take pills to try to mask a lack of healthy living, and then we take more pills to counteract the side effects of the original pill you were taking, and it just compounds, and so on and so forth.
Well, man, follow up that. You're talking about diet causing it and diet curing it. Talk about that for the people who want to do all things naturally.
Yeah, I think these vegan diets are amazing when you see what it does to your overall health. I mean, you can see diabetes drastically decreasing. Obviously, there's weight issues, arthritis you can see drastically decreases, overall inflammation from the lack of meat and protein products. It's quite amazing what we can do as a human to actually counterbalance negative things going on in our organism through the cutting out of meats and proteins, and really looking at plants and nuts, and really focusing on what we call today a vegan-based diet. I think there's a lot that we could all do, and unfortunately it's just not part of the culture. It is difficult to eat that way because there's so much around us that's quite accessible, cheap, and easy to get access to. But we can do a lot with diet that we don't need to rely on medications for.
So what are you doing? Are you vegan, or are you married, kids, and all that vegan? How's that working in the real world family home?
I'll tell you how. So I've got a 10-year-old and a 7-year-old. They do not enjoy the vegan diet. As you can imagine, kids don't love a lot of vegetables. And I would say we teeter back and forth between going plant-based and then going back to what we consider just a healthy diet that does include protein. We try to eat as healthy as we can, promote or limiting protein that comes in, and then trying to really promote plant-based with the kids. Not as easy is it not overly easy with kids as it is as an adult to make those decisions and move forward.
Oh, it's so hard. And then the worst part about it is when you do go vegan and you start doing your daily yoga and you get into it, even if you just do it for like 10 days, then when you fall off the wagon and go eat your meat lovers supreme pizza delivered to your house, you just feel horrible. I mean,
You do
and you
feel
know
different.
that it's like you love the taste, you love the food, and you're just sitting there feeling like, you just feel horrible. So
Yeah.
it's so obvious and it's so hard. That's what a so how do you see that moving forward? Plant-based diets.
Honestly, I don't. I don't think a lot of it is going to move forward. I think it's going to maintain on the or continue to be on the fringes. Um, it'd be amazing if you could take everybody who's teetering on type 2 diabetes and get them on plant-based diets, and if they would move forward and actually be good stewards of that type of diet. But I don't see that. And I think going back to the discussion on pharmaceuticals, I believe that pharmaceuticals is a big part of that issue. Why would you want to eat a plant-based diet when you can take your insulin on a daily basis and eat whatever you would like? Not understanding that there's so much other things that are going on downstream from the insulin, from the excess weight, from the diabetes. But when you can be treated through a pill or an injection, that's really not much work on your behalf, and you can just continue your life the way it's going.
Yeah, and another reason I think people don't like government involvement with healthcare is because it comes out of just weird judgmental stuff. Like they just released a big study that showed that globally diet kills more people than tobacco. And
Mm-hmm.
but tobacco, it's real easy to say, oh, it's bad. And right now, everybody's freaking out on vaping, and they'll show you like one guy died over here. It's like, yeah, one guy probably got hit by lightning too. But how come you
Sure.
don't take that ferocity at something like salt, where you look at the Centers for Disease Control studies, like, my gosh, you look at the biggest number, and you never talk about that hardly ever. And then you
Yeah.
shift down 3 or 4 smaller diseases and you're like obsessed with that. But I mean, like when people are discussing, well, I don't know if I want to be vegan. Well, forget vegan and non-vegan. Just start looking at salt.
Yeah.
That's still a people don't even really focus on that enough. What are your thoughts on that?
I think that's a great point, and I think it all boils down to acute versus chronic conditions. Going back to your vaping, we can immediately see in the moment poor reaction to vaping, and someone's going to the hospital. It takes years and years and years of excess salt to finally start manifesting itself. However, at that point in time, you may not have much going back. And I just think the human condition is programmed to what is immediate and what do I need to really focus on if it's going to affect me within the next day or week. And if things are not going to affect you for the next 20 years, it just doesn't seem like it's a top priority in change and making adjustments in lifestyle.
Yeah, the Mayo Clinic studies going back to the 80s where, when you have a sodium ion in there, remember the book, The K Factor, written by an MD with a PhD, and he says it takes 4 potassium ions to pump out 1 sodium ion. You're only going to get the potassium from plant. So if if you're living in a country where all the processed food, has several grams of sodium a day, it gets to the point where there's not enough bananas to eat to get this stuff out of there. So how much does this technology cost?
Good question. So we've tried to make it affordable. We do not want the barrier to entry to prevention being cost. So we have an opening package of $169 per month, which gives you 25 tests and the use of the machine. For high volume clinics, that goes as high as $600 per month. This is very much like a blood pressure test at a physician's office. You're getting a baseline read of your oral health through this machine, just like in a physician's office, a baseline read of your systemic health when we can correlate to blood pressure. And we want to be able to monitor that in perpetuity in a longitudinal way so that patients can see how their salivary flow is changing over a certain amount of time. So we do promote the testing of everybody but we do understand that not all dental clinics can adapt to that and put that in their process flow. So we do offer packages as little as $169 per month.
Okay, so your most basic intro package is $169 a month.
Correct.
And what would that include?
That includes the use of the device.
Now, do they own the device or are they leasing it?
We don't like to use the word lease, but yes, they are leasing it.
And what do you call the device?
The Boka Flow device.
The Boka Flow.
Mm-hmm.
Okay.
So they are leasing the device for that price, and then they are shipped 25 tests per month. So it's much like the razor blade model. You have the device, and then every patient you test, you need a new set of disposables to test each individual patient.
For 25 tests.
Yep.
So $169 a month you to use the Boka Flow device plus 25 tests.
Yeah, $169 to use the Boka Flow device and 25 tests per month.
And when did you start selling the doing this program? When did Boka start releasing the Boka Flow device?
Just in 2019. We've just slowly been releasing as of this year. We're probably only about 4 months in.
Okay, and then so I'm early bird. You heard it first on Dentistry Uncensored. I try to stay on top of everything.
Yes.
So
yeah, you're very early.
What's the next level up? The $169 a month. What's next up?
So for $349 per month, you get the device, the Boka Flow device, on a month-to-month basis, and 100 tests, and those are shipped directly to your office on a rolling basis every month.
So that's a Boka Flow device plus 100 tests.
Mm-hmm.
Okay.
Correct. And then the one up from that is $599 per month, and that gives you the Boka Flow device plus 200 tests shipped to your office per month. Okay,
so I know all the DSO kingpins, which I'm in Arizona, which is ground zero for DSOs. 18% of the dentists in Arizona are affiliated with the DSO, and some states that's less than 1%. So this is ground zero by far, and they're the ones that always, if it doesn't make sense in the business model, it's dead on arrival. So I always tell people, if you've got something that makes sense on a business deal, well, go talk to DSOs first, because they'll get it long before my homies in private practice will, who don't even, can't tell you any of their numbers. So if I was a DSO kingpin and I had 100 offices, they're going to ask things like, okay, so how do I get my money back?
Yeah, that's a great question. We're seeing numerous models that are being used. Some clinics are charging for the test. The average price that they're charging is about $10, and they're baking that in to the fee that they're charging for the cleaning or the biannual visit. There are codes that can be utilized to submit for reimbursement. DO 417 and DO 418 could possibly fit.
Say that again.
DO 417.
Okay.
And DO 418 could be coded for the use of our device. And in 2020, there's already projected we've already been told through the ADA that there will be a code that is specifically just for measuring salivary flow. As you can imagine, you can submit. It doesn't mean all insurance companies are going to reimburse. Because this is new and this is the first device of this kind on the market, we're not finding currently that a lot of insurance companies are reimbursing. So moving on to what else is going on. When you're preventing, Howard, as you know, you're also giving up some revenue on the back end. If you're preventing 5 cavities over the next 2 years in a particular patient, that's 5 cavities that you're not charging for and revenue that is not coming in. However, on the preventative care side, there is revenue to be made. So the ADA recommends that anyone that has dry mouth or low salivary flow receive their 5% fluoride varnish in the dental office. And on top of that, they return in 3 months for a follow-up, which can be charged to the patient to receive an additional fluoride varnish. We're seeing an uptick of anywhere between 50 and 100% acceptance rate of fluoride varnish use in the office for patients that have dry mouth. So this is providing a different revenue stream that they weren't previously receiving. There's also prescription strength fluoride gels, think like Prevident 5000, that if the office wants to hold and sell to the patient, could have a small uptick in revenue from that, in addition to professional strength oral health rinses that clinics can hold in stock and also offer. There are some prescription options for treatment, which one that we like is supersaturated calcium phosphate rinse. Obviously, there is no economic benefit for the dentist on that, but there is benefit to the patient. And what we're feeling and what we hope is that you're swapping out a small upfront additional charge to the patients for the preventative care, for the follow-up for some of these products, in exchange for the long-term sequelae that occurs with poor saliva flow. And by doing so, we also hope that patients are more happy with the care. They're willing to come in more often. They're willing to take the dentist recommendations, and they're willing to be more sticky as a patient through this type of care and treatment, rather than just getting x-rays, getting cavities filled, and washing and repeating this process over and over.
So do you, you being a physician and now being in the world of dentistry, do you think physicians have a bigger disconnect with dentistry than, say, physicians versus, say, dermatologists, ear, nose, and throats, all the other specialties? Do you believe that?
Sorry, I didn't quite understand. Do I believe what?
That we're kind of disconnected with healthcare more than say a dermatologist, an ophthalmologist. I mean, I still, you always see charts, and two of my pet peeves is that they'll give a statistic about, certain amount of people do this, but am I just assume those were just American people or the whole population? And when they say the most trusted profession, they say doctors, but you look at the whole list of 20, dentists aren't on there. Is that supposed to be one? So what do you think of the current relationship between dentists and physicians in the minds of the patients?
Yeah.
If your physician told you any advice on any body part, you'd listen. But so how is this going to be perceived when the dentists start talking about things other than the oral cavity?
Yeah. Well, I think this is an interesting point. I do not think there's much correlation or continuity between dentists and physicians in the United States. One thing that I loved about my clinics down in Brazil was we almost always had physicians and dentists on staff at the same time. And Howard, is very interesting to see the interaction between the physicians and dentists. And it went both ways. It was not just the dentist going and asking the physicians to look at issues that may have been going on. It was the physicians also asking for a lot of recommendations and help from the dentists. And working in that multidisciplinary care just created a seamless transition. And in those clinics, you didn't see much of a divide between a dentist and a physician regarding health. Another example is at Albert Einstein in our oncology department. As you would know, chemotherapy is one of the largest wreckers of teeth that you can find. You just knock out all salivary flow. And many chemotherapy patients, once they're done with their chemotherapy treatment, have no teeth. Well, at Albert Einstein, we had dentists full-time on staff seeing those patients every time they came in for treatment in the oncology department. We love that interaction. You don't want to treat someone's cancer and then leave them with an additional $20,000 worth of dental care that needs to be done because none of their oral health was monitored during their treatment. Coming back to this, we believe that through this type of preventative care, through the dentist being more interactive with what type of medications the patient is on, what is going on with their salivary flow, looking and monitoring for things like Sjogren's and lupus. These are autoimmune diseases that we feel the dentist should be the frontline screener for. It shouldn't be the rheumatologist or the family practitioner. If the dentist is testing everybody, the type of patient, if it's a female in her early to mid 30s and has extremely low salivary flow without medications, we need to start thinking this could be an autoimmune disease, and we need to be referring to the medical side. We hope that this can bridge that gap a little bit, and that the patient, when they go see the dentist, isn't only feeling like they're just looking at my teeth, but they are looking at my entire system and my entire organism.
So is that the lion's share of starting with this is Sjogren's syndrome, which attacks the glands that make tears and saliva, and lupus? Is that the 80, if you talk about the 80-20 rule, is that the 80% where the main focus?
With our platform and device?
Mm-hmm. For xerostomia. I mean, when so there's dentist concerns, patient concerns. So when it looks like, what is the dentist measuring? What is he most weighted concern for? Would it be Sjogren's syndrome and lupus?
For the dentist, no. For the dentist, this would be polypharmacy, hyposalivation due to excessive medication. That is going to be the lion's share of what the dentist sees. Someone is dry because of the medication that they are on. On the fringes, so the smaller portion of the population, you may see people that are dry because of Sjogren's and lupus, and then also chemotherapy patients that are undergoing chemotherapy. But the lion's share of everybody they're going to see is the normal everyday person walking around in the population that is on 3 to 5 medications, and because of that, their saliva is low. And now, because of low saliva, they're going into the dentist, and every 6 months they have 3 or 4 additional cavities. It's interesting when we hear about these patients saying, every time I go in, it's another 3 cavities, it's another 4 cavities. And the first time our device gets implemented into a clinic and they get tested and they're below 0.1, below that threshold, it's very quick to realize what's going on and why. Even when they come in and say, I brush my teeth and I've got good oral hygiene, but I still keep getting cavities. Well, if you don't have saliva protecting your teeth 23 and a half hours a day, taking out when you're rinsing your mouth and eating and brushing, you're going to begin to have problems. And that's what the patients or the dentists are focusing on, helping those patients, getting them on a treatment protocol and increasing their saliva, or also providing protective factors so that every time they come in, every 6 months, they don't have 3 to 4 additional cavities.
Yeah, and the polypharmacy, how many medications do you say it takes to be considered polypharmacy? Are you going with 5?
We're looking at 5 as the threshold where we start thinking this is going to be serious. You're going to have extremely low saliva flow.
And remember, that's just not prescriptions. Prescription is just a regulatory deal. These people go to nutrition places. I got people that eat 1,000 milligrams of vitamin C every day just because that's what they believe. So it's just 5 really concentrated things. And so what I'm reading, it's 40% of the older adults, of elderly, but for adults, it's usually those with some type of intellectual disability. So all the psychiatric ADD, the kids are on it. They start pumping them with all these pills too. So it's elderly, 40%, intellectual disability, 21%. Those are doctor, physician, dentist concerns. What is the patient usually focused on when they're asking for help with xerostomia? What is their discomfort? Why are they not liking it and talking about it?
Yeah, no, that's the great point. We're really trying to get out. Part of our platform is we need to educate the patient. Generally, the patient doesn't notice that they have low salivary flow or dry mouth until about 50% of the flow has been reduced. It's a slow process. Then they start noticing, and they start noticing things where it's hard to eat. It can be hard to talk. more difficult to swallow. So these are kind of the mechanical things that they're noticing. What we're finding is most patients don't understand that there is a direct link between this dryness that you're feeling and oral health disease. We need to fill in that gap to where they understand, yes, there's some mechanical issues and discomfort that you're having, but what's really occurring is increase in cavities, increase of in periodontal disease, increase in all these additional items that they're going to need to be treated for. So as you can imagine, not many patients go in complaining of this because they don't quite understand the severity of what's going on in their mouth when they have dry mouth.
So in Dental Town in February, we had an article on electrostimulation and xerostomia. What are your thoughts on going into, okay, so you get a measurement, it's under 0.1 milliliters flow. So now you want to treat that. What are you doing?
Yeah, so I think that electrostimulation is interesting because I think there's some treatment options that are to increase the salivary flow. And then there's other treatment options that are going to act as a protection to your teeth, and they don't necessarily increase salivary flow. So electrostimulation is an interesting one because that has been shown to increase salivary flow. Another item would be something like pilocarpine, which can be given, again, we're going back to the pharmaceutical, but that can increase your salivary flow in hopes of just having more saliva in the mouth. So these are interesting mechanisms that a patient can look at to just increase the amount of flow. The other items like the fluoride, the oral health rinses, calcium phosphate rinses to an extent are more protective. So even if you do have the low saliva, these protective mechanisms should help and will help your oral health.
And which company's products did you mention earlier that you like the most? You have your faves?
So we've worked with Forward Science, and their supersaturated calcium phosphate rinse is called Saliva Max. That was originally came out to treat mucositis in cancer patients, but it's also been shown to help in remineralization and increase baseline salivary flow. Things like pilocarpine, a systemic drug that will increase production of saliva. Those are generic, very cheap. A lot of dentists can also offer that in lollipops or Tic Tac size, so it's more localized. And then we've got some other items like OraCare on the oral health rinse. I think Closis is an interesting one because it also helps out with pH. And then you have the prescription strength fluoride gels. And we've got interesting companies like Elevate Oral Care that has a whole suite of items that you can utilize for dry mouth when you're looking at xylitol mints, the fluoride gels, et cetera, that can be used at home.
So talk about, there might be a lot of kids with a pilocarpine induced salivary flu over their head. Is that getting more common? Do you see that? Is that a popular treatment?
It is not, and I think it should be used more widely. The issue with pilocarpine is it not only activates your salivary glands, but any gland that secretes a serous fluid, most often your sweat glands, it also activates. So one of the big problems is people complain that their hands and their back and their feet become extremely sweaty. So the dentist needs to recognize that there needs to be a titration period and a little bit of hand holding with the patient. And when I say titration period, we don't want to give the patient the immediate full 5 milligram dose. Slowly work up to the dose where you can feel like the salivary flow has increased, but your sweat gland and the rest of the glands in your body have not increased in their production as well. So there needs to be a more interaction on that. But once you get to that baseline, that is something that you can take that will activate your salivary glands. I also think the dentist should look at and think a lot about the local pilocarpine usage. So the lollipops, little Tic Tacs that you can get at specialized pharmacies. As you know, they're not commercially readily available. So you do need to go through a specialized pharmacy and request that formulary. But a small Tic Tac just used in the mouth, not to be swallowed, 5 milligrams of pilocarpine, patient pops it in. It generally works on the local level, so they don't get a lot of the systemic effects of pilocarpine. And through doing so, that will increase salivary flow. For people that are in the xerostomia range that are going to have real issues, I believe they need some of these stimulating factors, whether it be pilocarpine, whether it be Saliva Max, or whether it be electrostimulation. They need something to get that stimulated rather than simply relying on fluoride to provide the protection.
And rank those in order of how you would do it for yourself. Pilocarpine, electrostimulation. Put them in order if it was you. What order would you put that in for yourself?
If I was extremely low, I would be using pilocarpine and the supersaturated calcium phosphate rinse as my first defense in regards to getting my saliva up and getting immediate protection. On the back end, I would also be using some sort of oral health rinse like Oracare or something that's focused on dry mouth, in addition to at-home use of the fluoride gel, Prevenant 5000, or anything that's 5,000 parts per million. I would be attacking it with all four of those, but the front line of increasing saliva would be very important to me.
Okay, so say it again. Pilocarpine would be number one?
I would use pilocarpine in conjunction with the supersaturated calcium phosphate rinse.
Made by Forward Science?
I like their product. I think they have a great product.
So that's a mouthwash.
It is. Comes in a sachet, a powdered sachet that you can carry around in your purse. You add a milliliter of water to it, throw it in your mouth for a couple minutes, spit it out. It's got a lot of the ions in it that can add to the minerals that you need for your teeth, and it has been clinically proven to increase salivary flow. So the pilocarpine and the Saliva Max can both increase your baseline saliva flow. And then we want the patient to go in and continue to be tested so they can monitor how this is going in a longitudinal basis to figure out where they are now at on their baseline with the pilocarpine and the Saliva Max.
And what percent of my homies probably don't even know what pilocaine is and have never used pilocarpine is and has never used it? And how big is the knowledge gap, do you think? Because, I mean, dentists, even when they just do something they really, really know, like a denture or a partial, but if they only do it once or twice a year, it's so hard to keep right on top of something, whereas you're doing fillings every day.
Yes. No, it's a great question. We're seeing that most dentists, I would probably say anywhere between 70 and 80, want to be walked through and understand the treatment options. I don't think this is the fault of the dentists or the education at all. I think it's an issue of we just have never had a diagnostic device to measure saliva flow before. And it's just natural that if you don't have something to measure, you don't really look a lot at treatment. And if that's just not top of mind, it's just not part of your clinic. I really do believe that once this begins to be part of the overall treatment, part of the gold standard of your care when you're going in, the treatment's going to be much more top of mind and much easier to get access to. I also think that because of Boka Sciences and the Boka Flow device, that there's going to be more innovations coming from big companies that want to attack the xerostomia and dry mouth market. With a diagnostic, there's bound to be innovations in how to better treat patients that have xerostomia.
So are you, who is your product champion in dentistry? Who's going to be your, the guy, you need an outside man, you need a product champion. Have you started isolating dentists to be your product champion for this, to talk about it, lecture, make online CE, or what are your thoughts on that?
A good question. We've done a lot of research with the University of Utah. A saliva specialist there named Dr. Melody Weller has been great, and her colleague Brian Trump. We've also published with West Coast University and the individuals there looking at populational data, how many people have dry mouth, et cetera. And then we've been working with people like Brian Novi, who is wonderful and very well respected in the field. Tina Pappas, I think she's great. She has the device and speaks about it. She's been working on saliva and saliva flow and xerostomia for most of her career. She's at Tufts University. As you know, Brian Novi used to be at DentaQuest and part of their preventative dentistry program, and is now working in Massachusetts with some other clinics. Stephen Powell at Loma Linda is a great champion. We've got a lot of really wonderful people, and I can't leave off Rory Hume, who's the dean of the University of Utah School of Dentistry. He's wonderful. He understands the issue, has been very helpful in both educating us and helping us understand how we need to position this and how we can create a preventative platform.
And so are these you're in Utah. Have you talked to Gordon about this? He's considered by everyone who's at least over 50 the god of dentistry. Have you ran this by Gordon and Rella?
Gordon has it, and this has become an integral part of Rella and her research staff's process. They're doing incredible research on the type of bacteria and the depth that goes into cavitous lesions, what bacteria, what depths, and what is actually causing the issues. And they have woven in with this research protocol full dry mouth screening for these patients to now begin to correlate. Is there a correlation between dry mouth, lack of saliva, and the type of bacteria that's in the mouth and the depths that those bacteria go? So they've been working with us very carefully and have been, again, wonderful champions. And we love that they're using our device for research. We found that this has ended up being an interesting foray into the research field. Rella always says, I'm so glad I don't have to have my patients drooling in a cup for 10 minutes. Not only is it uncomfortable to them, it's not overly accurate, and it takes a long time. Now they can test and measure salivary flow for these patients, along the course of the day. These patients often spend 10 hours in the chair. They can see the longitudinal data in conjunction. So they've been wonderful, and we will continue to work with them.
But Saliva Max is still your top pick for treatment. This,
I think Saliva Max is wonderful when you're at the very low ends. Remembering though that Saliva Max doesn't have the fluoride component, so we need to remember every patient that is dry or hyposalivation needs to receive their 5% fluoride varnish in the office, and they need to follow up with the dentist and receive another 3-month fluoride varnish. So it needs to be compounding. I wouldn't say there's one silver bullet right now that you can just say, this is what it is. It's the only thing you need to use. I think each of them have a different mechanism, and they should be used in conjunction. And that's where the dentists need to create that care protocol, and we're trying to work with them to do so and find the best options. But yes, I think Saliva Max is a wonderful start for people that are low. It often can be covered by medical insurance, so it's not an out-of-pocket expense, going back to our insurance discussion. And some of these others are an out-of-pocket expense, but they're needed as well on top of that.
Like even yesterday, I mean, you were talking earlier about how when we started this conversation that your dental clinics all had physicians. It's dental medical clinic. And like in a dental office, the question is, oh, well, her blood pressure is high. I don't think we should work on her today. And you're going to send her on her way. Whereas, I mean, that didn't solve anything, No. If a physician was there, we just kept going. I wonder how technology and teledentistry and telemedicine will start making this all work closer together for the individual who doesn't want to drive all around town seeing a different doctor in a different corner of Phoenix every other day,
Yeah. I think the universities are going to push this. Just this year, the University of Utah, here in my backyard and where I went to medical school, has integrated their EMR. So now the dentists and the physicians utilize the same EMR. So it's very interesting.
EMR, EMR.
Electronic medical record.
Okay.
Yes. So they're using the Epic platform is what the EMR is called, and it has a dentistry platform. So now, if you're getting treated at the University of Utah by your dentist, the dentist has full access to your healthcare records on the medical side, and the physician, vice versa, has full access to your dental care. What this is allowing is you don't have to do a tedious medication reconciliation with your patient, because you can see it right on the computer as they come in. You can see what their past blood sugars were when their exams were done, their past blood pressures. It's allowing it to seamlessly integrate. This is going to be, I think, the first step and the future of combining the two professions, is having one single electronic platform that is curating all of your data, so the dentist and the physician can see what one or the other are doing.
Well, yeah, and what you just said is really the entire problem. I mean, like you like go into a dental office, their practice management software doesn't talk to their accounting software.
Yeah.
You look at research around the world; they're all on different platforms. You look at a lot of the research; it's all duplicate. I mean, a team is doing this in China, India, and Brazil, and that's all already been done. And if they were all synchronized together, they'd be onto something else. Last and final question, just to the kids out there, you're seeing that back when I was just getting out of school, they would sell a device like this, and it was feast or famine. You would sell a device like a $50,000 YAG laser, and after you sold 1,000, if you didn't sell any for several months, you're out of business. So they're always trying to get revenue streams. He said he didn't want to use the term lease, but whenever you make a relationship with a company, like say Netflix, where you say you're going to give them $10 every month into perpetuity, well, now they can budget a bunch of big movies and blockbusters. So if you want your company that you're working with to be healthy, they pay their bills monthly, just like you pay your bills monthly. So a revenue stream, if you're coming out with a business where you sell it one time, there's no revenue stream, there's no disposables, there's nothing to work with. You kind of got a dead platform. That's why some businesses are so challenging. So when you sit there and you're leasing a machine so they can count on subscribers, and then you'll have this data coming in, which will give you bigger and bigger data, so that eventually AI can come in and start machine learning, and then combining that with the medical records. And I mean, if we start doing this, God, just think what it'd look like for the next generation.
Yeah. Well, and I think that's a great point. We need to constantly be innovating and providing value, not just being stagnant. And in our next phase, to your point, we're working on finalizing a software platform where, as the patient leaves the office, they immediately get a text saying, what was your salivary flow rate and where do you lie in the risk profile? This machine bot that we're developing and creating, and it should be up and going in a couple of weeks, will then walk the patient through what is xerostomia, why do you have it, now what can you do for it? And it's very interactive on treatment options, education, what can you do at home to alleviate the discomfort. And we want to have that constant interaction with the patient. And this can come in the guise of from the clinic and also interacting with the dental clinic. But we want to make sure that we're educating properly. Part of this is diagnosis, treatment, and education. And we need to fill all those three buckets so that we continue to provide the maximum benefit to the patient as they're trying to prevent and be as healthy as they possibly can.
And this is why Dental Town we just came up on our 250,000th register member. We're still signing 1,000 new dentists a month. It's because of the message board format. It's not like Facebook, Twitter, and LinkedIn, last in, first out. You're just scrolling in this, endlessly. So that when you have a specific question, like if you just take the word xerostomia, or pilocarpine or just something specific, you would pull up every single thread and post that ever mentioned this since day one. And it's just such a organized matter. That's why when you go to the Jet Propulsion Laboratory and ask them if they're studying Mars on Facebook, it's all message board format, or they used to call it bulletin board format. But you can go in, you can type in one word. So I hope you join the discussion and illuminate this area for dentists, because it's going to be a growing concern. And it was an honor for you to come on the show today. Thank you so much for coming on the show and telling us everything you know about xerostomia.
Well, thank you for having me. It's been a pleasure, and I really appreciate it.